Well, here it goes, 2025, show number 3. And this episode of the Inside EMS podcast is sponsored by Philips. Time to take pre-hospital emergency care to the next level. Time for Tempest. I got to tell you, man, ladies and gentlemen, we are really starting to get going and rolling for 2025, but I can't do it without my good friend, the one they call Kelly Grayson. Kelly Grayson, KG, what's going on up there in the world famous Empire State?
We're just looking forward to the polar vortex later on this week, and I finally added weight training to my exercise regimen. So in addition to swimming 9 kilometers a week, I'm working out, lifting weights, and my arms are feeling it right now, brother.
Kilometers? What is this, Spain? What are you talking
Excuse
about?
me, 5.66 miles. What was it to say?
Kelly,
There's two
what the
types of
heck are you doing?
countries.
Kilometers.
Two types of countries.
I gotta break out my calculator. Cut it
Yeah,
out.
those
Okay.
countries that have put men on the moon, and those countries that use a metric system. Yeah.
Those countries. So, we got a really great show for you. And, Kelly, you're kind of bringing this show to us. So we got a guest. You see him down there if you're watching us on YouTube. Tim Redding, paramedic, instructor. He is the president, the founder, the head bottle washer of Emergency Education Consultants. And he's here because of a class that he did at the Texas EMS conference back in November of 2024. So Kelly, why don't you go ahead and set it up and we'll go from there.
Yeah, this Tim's class, Sex Matters, was an eye opener for me. We've all been taught that women have different presentations, physical presentations, and different symptoms for, say, cardiac issues and so on and so forth, and that women tend to have atypical presentation for this and that. And I sat in Tim's class with the expectation that I hear a bunch of that, and my eyes were opened by how much medicine, period, not just symptomatology, but research and everything else, is male-centric, white males only for most of it. And it was kind of an eye-opener and a shock to me. So Tim, why don't you take the first part? Why don't you tell us what exactly is male-centric medicine?
Sure. I want to give credit where credit's due, and thanks for having me, guys. I think this is an important message to get out to EMS providers. So I have a friend, and her name is Dr. Alyson McGregor. She's one of the country's leading experts in women's health and gender medicine, things like that. And she wrote a book about 4 or 5 years ago. And it's called Sex Matters: How Male-Centric Medicine Endangers Women's Health and What We Can Do About it. So I read it. I listened to it first on audiobook, and I was kind of blown away. So many things I didn't know. And my first thought was, as I'm sure it's the same with you two in a lot of cases, I need to make this a presentation for conferences to get this out to other folks. And so I talked to Alyson and worked on the presentation, and she okayed it. I read the book again, a bunch of the articles and references. And so I first did it at a conference in January of 2024. And I have to say, I thought there'd be 4 people in the class, 4 women, and there was about 80 in the class, and about a third of them were men, which I was really happy and surprised about. So I've been doing that both locally and some other conferences. And what it comes down to is we all have implicit bias, which is bias that we don't know we have. It happens when people develop software, and sort of happens in all aspects of life. So if you look at the history of medicine historically has been, go back to the beginning of doctors, has been white males doing the doctoring and writing the textbooks, doing the studies, etc. So what that has led to, by no one's fault, it's led to this very male-centric view of medicine. If I were to ask you, what are the signs and symptoms of a stroke, you would say facial weakness and arm drift and things like that, which can happen in women, but more often than not, that's way more common in men. Women present with a headache or altered mental status. And that's just one small example of what male-centric medicine is.
You know, what's interesting as I'm listening to you talk about this is the fact that, medicine is very traditional, and we know that medicine is very traditional. And even though we find a lot more women in medicine, a lot more researchers in female researchers in medicine, it seems that as we talk about this and just this couple of minutes, Tim, that we've been spending here, it really is the paradigm that needs to change. But you would think that in the day of, female professionals, female doctors who are running schools and, medical schools, and who are, really doing research, that this is still a topic. I mean, is this something you ever get out from under? And I know that this question may be coming off script, but it really is something that I think we have to think about, because as you mentioned, as soon as you said the stroke thing, the thing that got to me was a, 50-year-old, slightly overweight female who's having a heart attack, presents with symptoms of abdominal pain. And we're not taught that in school. We're taught that, Levine sign and Elizabeth, I'm coming to join you, honey, and the whole 9 yards, right? But I don't even know if there's a question in there, Tim. I'm just amazed.
How do we
Yeah.
overcome that bias?
Yeah.
Right. First off, about half your audience will understand the reference. I'm coming to join you, Elizabeth, but great reference. So I think it is hard, right? In medicine in general, not just in EMS, we don't like change. It's we work so hard in EMT or A or paramedic school to develop this initial info. We don't want to let go of it. So it's very hard to change. And this is one of those things, like a million others we can think of, that we sort of have to work hard and force ourselves to change and realize that women don't present like men with heart attack and stroke. Women don't respond pharmacologically the same way that men do to drugs. And there's a million other examples in the book that we need to be aware of and force ourselves to change, which is really hard work.
Yeah, the good news being is that you said you had 1/3 of the audience was men in your first lecture. You had what, 200 people in your room in Texas, and I would say over half of those were men. So, continuing education wise, they understand that there's an issue and they seek more knowledge of it. Contrasted to every initial EMT or paramedic class I teach, the big chore is obstetrics and gynecology and the reproductive system. You have to constantly remind your male classmates to stop the "that's what she said" stuff, and still it's probably one of the most failed parts of the National Registry exam, even for female test takers. What I don't quite understand, this deal with not responding pharmacologically like males do. It's a good example of male-centric research on medication. Can you give us some examples of other medications that were primarily researched only on men to deleterious results?
Sure. The quick answer would be one of the most widely prescribed medication in the US is lisinopril, an ACE inhibitor, Zestril, which initial studies was never studied on women, only men. Some of the statins were only studied on men. In 2001, a government accountability study came out, and what they looked at was in the 4 previous years, from 97 to 2001, there were 10 drugs taken off the market. So the FDA approved them, they started prescribing it, and then for reasons, they took it off the market. 8 out of those 10, the reasons were severe side effects in women. And the reason they didn't know that's 80%, is because they didn't study it in women. And there's some historical reasons I can give you for that if you guys really wanted to get into that. It's getting better. I believe the last couple of years, most studies, particularly drug studies, have 38, 35% women, although women are 50% of the population in the US, but that's in phase 3 drug trials. Without getting too much into that, that's sort of the end phases of a drug trial, phase 3 and 4. So yeah, I mean, we're still only seeing a third of women in trials, even though they're half of the population.
Didn't you say in the lecture that thalidomide back in the day was only studied on men, and we remind us of the results of that problem?
Yeah, so there's really two things that happen historically when it comes to sort of studies and particularly drug trials, but studies. And one of them was World War II. So we know what happened in World War II with the Nazi human experiments. And because that horrible thing happened, when post World War II in the United States, the folks got together and kind of said, we need to make studies way more stringent. We need to make some rules behind them and some ethical guidelines behind them. So that happened. And then on top of that, a little bit after, was a drug called thalidomide that had many uses, but one of them was for morning sickness for women that are pregnant. So a bunch of pregnant women got this in the United States and Europe and England. And there was about 100,000 babies born with these really, really bad defects, no arms, no legs, and those were called the thalidomide babies. So because of that, because we're a reactive sort of country particularly, what they did was they said, if you want women in your studies, this is mid 60s, if you want women in your studies, you have to do things like give them pregnancy tests. So if you think about if you want to study 1,000 people and have 400 of them, 300 of them be women, and your trial's going to last a year or two, that's a lot of money in the trial. So the folks that give the grants stopped giving grants for folks that had females in the study, and basically the FDA came down and had these guidelines. So the folks doing research just said, well, we can solve this easily enough. Let's just not have anybody that's of pregnancy age be in these studies, right? No females. So for a couple of decades, late 60s, 70s, 80s, there just weren't women in drug trials.
So
And
the
then
FDA learned exactly the wrong lesson
Right.
from that deal.
Yeah. And that really is what changed. I mean, in that study with thalidomide, that's really what changed kind of how drugs were tested, right? And it was a really, really tough time because these kids, didn't do nothing wrong. And then the females took this drug and it was really horrible for them. But let's go ahead and take a quick break. And then when we come back, Tim, I'm going to ask you the question, well, what's an EMS provider supposed to do when he's already got the knowledge that was taught? And Kelly has said it for a lot of years, man. 50% of what we learn in EMS or in medicine is wrong. We just don't know which 50%. But let's go ahead and take a quick break and we'll go ahead and pick that back up on the other side. Emergency care teams need to focus on patients, not their equipment. The Tempest ALS lets you automatically capture and share patient vitals, treatments, images, and therapy with receiving facilities and to your EPCR. To help you focus on what matters, visit usa.philips.com for more information. All right, Tim. So really, I mean, we've got an awesome topic here, and I'm just really confused about all these things that you're talking about, which totally makes sense. But until you bring this to Texas EMS, I'm not sure that anybody was really considering it, and which is really novel for you. And as the president and founder of Emergency Education Consultants, this is the type of stuff we'd expect from you to really bring into the EMS field to say, have you considered this? Well, right now on this show, the answer is no, we haven't. But so as we now think about this from a standpoint of, what we may be doing wrong, how are we now trying to figure out the future of EMS and treatment and management if we've only been taught, symptoms that may not result to half our population?
That's a great question. So any change comes with sort of hard work, right? And the sort of disconfirmation of things that you've known or heard. So I think the first thing that needs to happen is the message needs to get out there more. Now, I don't know if that means a page or two in the EMS, EMT, paramedic textbooks to start with initial education, or maybe the lecture that I do with this in conferences and locally is 60 to 90 minutes. So maybe 1 hour of paramedic school, EMT school, A school on this, and that way they're learning it in their initial program. But for the folks already out there, which is who I deal with. I don't typically do initial courses. I do Con Ed and consultation. And I think we need to be, and this is hard, we need to be open-minded enough to pay attention to the lesson. We need to get the lesson out there more. And my friend, Dr. Alyson McGregor, who is one of the people that are experts in this, she recently, we were texting and she said, how can I help you get this message out to EMS providers, right? So we're going to try to figure out a way, whether it's podcasts like this and other things, because she's the expert and I'm the EMS expert, that we can work together to try to get this message out. But once the message is out, I think we need to be able to spread the message, which means buy into the message. So that way the person that saw the class in Texas or I've done it at 4 conferences in 2024, and it's scheduled already for a couple in 2025. Those folks that sit in the conference need to get that word out to the folks that weren't at the conference. We need to read more literature about it. We need to listen to more podcasts about it. And I think eventually you saturate sort of the market with this, and over the next.
It's kind of the wrong way though, right? I mean, the people who are creating the curriculums and the people who are writing the books, it's good that if the field paramedic hears this, right? Because at least it now gives them the opportunity to start to think, all right, what else could this be? And this goes back to the old days, Tim, of even differential diagnosis. I got to tell you, I mean, I've told this story before on this podcast, and it kind of goes along with this. It was a female patient, but we got a call to a rehab hospital of a patient who was having a stroke. And she came in for knee replacement. She was in a rehab hospital. We took her, I went in, she had a little bit of drooling, a little bit of facial droop. She was unconscious. She had an IV in place, put her on the stretcher, took her to the hospital. I mean, a couple miles away. Vital signs, EKGs. 2 hours later, I went back. They accidentally gave her the insulin that was meant for the woman in the other bed. So the reason I tell that story isn't because it goes into this topic, but it's sometimes we get tunnel vision and we think we know what's going on and we don't use the differential diagnosis process. But I was setting this question up to say is, what power does the field person have other than to change their practices?
Right. And I think that's what the sort of thing I talk about at the end when tying this subject up is you, the field providers, are the change agent. So at first, just change your practice, right? And then with your partners in the truck and change their practice, and then they'll work with somebody else. But I agree. So at a local level, it's changing it with your practice, but then at the national level, this needs to be sort of, again, whether it's a couple separate pages in the textbooks or whatever it is, we need to get the message out more nationally. Totally agree.
And the insidious thing about this is the more experienced you are, the harder this hits you, the more likely you are to make these mistakes. You stay in EMS long enough and you assess enough people, you eventually become a master at pattern recognition. But the flip side of that is you tend to ignore things that do not fit the pattern. And when we realize, albeit often too late, that females often don't fit what we consider the standard pattern, the consequences can be pretty dire. You were talking about the difference in presentation in females with stroke. We know, but it's a good reminder, what are the differences in presentation for females with MI and other cardiac issues?
Yeah, one of the biggest things that blew me away in the book was, so the book is sort of divided into 6 chapters, and one of the chapters is hearts and minds, and it's about this subject. So women, when everybody learns how an MI happens, we all learn that in one of the bigger arteries, plaque builds up in the vessel, and then your unlucky day is today, the plaque ruptures, it's sticky, platelets stick to it, forms a blood clot, blocks that area. And so when you do a cath and when you do a stress test and things like that, you'll see changes. In women, that doesn't happen most of the time. Women build their plaque up, it dissolves in the smaller vessels and they get stiffer. So when those vessels finally go and narrow and get blocked, you don't see the same symptoms. You don't hear the same complaints. Not only that, but the things that we think of for diagnosis, particularly in like the ER, like stress tests, like echoes, like the cath lab, most of those EKGs are different in women. The most accurate tool for confirming and diagnosed MI in women is an MRI, and that really blew my mind.
Me,
And the thing is, how have any of us, we even though we're pre-hospital, a lot of my career has been hospital-based systems. So I happen to work for that hospital and can follow the patient and see. And I can't think of any time that I've heard a doc say, let's get an MRI for that cardiac female patient.
yeah.
Yeah, I mean,
You
that's
know,
just,
it's not just what most people think is just that the difference is the way women process and express pain, and the women are much more stoic than men. What's the saying? A woman who's had natural childbirth almost knows what it's like for a man to feel a fever. But it's actually a difference in physiology. Their bodies respond differently. Their MI is
yeah.
different than a male's, and that's the thing that just blew my mind in your lecture. So when we come to wrapping this up, this is a topic that, unless Chris, you have another question.
Yeah, I do want to
Yeah, go on
jump
with
into
it.
one more, man, because this is such a, and what's the quote from Blazing Saddles? My mind is a raging torrent flooded
Torrent
with
flooded with
rivulets
rivulets of
of
thought
thought
cascading
cascading
into
into
a
a
waterfall of
waterfall of
creative
creative
alternatives.
right? I mean, there's just so much stuff that's
That's
going
right.
on here. But here's one of the last questions I wanted to ask you, Tim, because I think, we kind of glazed over it, but I think it's really important for this show. You talked about changing practice, the EMS providers changing practice. Give them a couple examples of what that means.
Sure. So this actually ties into what Kelly was just talking about with MIs. So everyone knows to ask about risk factors. Do they have diabetes and hypertension and sedentary lifestyle? Blah 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 blah. But there's a huge correlation with MIs in women that have a rheumatoid arthritis and lupus and arthritis type diseases, which are rheumatoid arthritis is 77% of women, and that hugely increases their likeliness of an MI. And believe it or not, OB complications when you had children. Early period, early menopause, placenta previa, gestational diabetes, even if the woman had her babies 30 years ago. So now for my practice, when I read that and read up a couple of other things, because there's lots of references out there, you just have to sort of find them and look for them. Luckily, I had Alyson that I know that could give me a bunch of references and websites and things. I was kind of blown away by that. So now with my practice, if it's a woman, and most people know, if a woman says, my head is foggy, or I just don't feel right today, you probably should do a 12 lead on that woman, especially if she's elderly. But now I don't just ask the risk factors. I ask about OB complications. I ask about rheumatoid arthritis. Women that you're just not sure what's going on, headache, UTI, with confirmation bias and with anchoring bias. We know that if you see a woman with a UTI, especially an older woman, automatically, or with altered mental status, you automatically think UTI. Altered mental status is a finding with women in stroke, but we just say it's UTI. So I've changed my practice a lot with assessment, sort of again keeping that once you're aware of bias, you're more likely to sort of catch it, right? So really trying to ask different questions and keep on my mind open that this could be a drug interaction, because that drug was studied on men and the dosage they figured out was 10 milligrams, and women get it for the first time, and 10 milligrams is way too much for them, and they have to change the dosing in women after the fact. That the example I'm giving you is Ambien. So now I have much more of an open mind when it comes to assessing an index of suspicion.
Yeah.
I mean, one of the things, if you think about, and I know we're getting up there in time, and I'm going to give it to Kelly to close. It's one of those things where you constantly hear women who are on blood pressure medicine that they're having a lot of challenge, that they have to go back and they're constantly, and I remember saying this, just go back to your doc, have them change a dose, but they're given male doses, obviously, right?
And orthostatic
Exactly.
syncope and
then the last question I have is, how do Kelly and I get one of those sweatshirts you're wearing? So I'll take mine in a 2X. Kelly, what size are you?
2X.
I am a 2X now as well.
All right, there you go. So 2X.
I'll take care of that. Although I did last year change the logo, so I'm still deciding if I want to make the clothing order in the new logo.
Yeah, so
I'll send it to you. It's fleece. It's nice.
Good. Very nice. But thanks for coming on, Tim.
Yeah.
Appreciate
So
it.
Tim,
Thank you for having me.
Where can we hear this lecture in 2025?
Ooh, so I'm actually waiting for a couple of places, most likely, not for sure, but most likely Alaska in November. I was supposed to do this topic last year in November, and I had to cancel at the last minute. First conference I've ever had to cancel on. And so I'd imagine maybe they're going to have me back and do this one again. And I've applied to a bunch of others and waiting to hear back. But what I can tell you is, since mid 2023, late 2023, when I started applying for conferences and put this lecture in when I submitted, it's gotten chosen, I think, at every one I put in for, which is good, because it means the conference organizers and committees realize the value.
And there you go. That if something you haven't considered for your upcoming conference, is a good addition to your slate of speakers. But hey, you've heard what we think. We'd like to hear what you think. What did they teach you different about females in patient presentation, research, everything else? How open is your mind when you're assessing a patient? Is this something we need more education on? Should we do something like National Registry has done and require more pediatric education and continuing education? Should we add female education to the National Continued Competency Program? We'd love to hear your thoughts at the show at ems1.com. And for myself, co-host Chris Ceballero, and our special guest this week, Tim Redding, thanks for tuning in to Inside EMS. Going to catch y'all next week.